So I wanted to talk about pulp caps, and specifically the difference between direct and an indirect pulp cap. So let's start with a direct pulp cap. So by definition, a direct pulp cap means you have a pulp exposure. Could be micro, could be bigger, but you definitely know you've exposed the pulp. So what do? If we expose the pulp of the tooth, the very first thing we need to do is we need to get hemostasis. How do we do that? We're gonna take something that's moist and we're gonna apply direct pressure and for 5 minutes. My preference is just a cotton pellet, moisten it with a little bit of water, and then direct pressure, set a timer for 5 minutes. And at the end of 5 minutes, when we pick up that little cotton pellet, we should have hemostasis. If the pulp is still bleeding after 5 minutes of direct pressure, the chances of the pulp surviving are so low that the recommendation is refer the patient, do the endo, time for a root canal. The difference with an indirect pulp cap is in an indirect pulp cap, not only are we saying we don't have an exposure that we're aware of, but we're actually saying that with intention, we've left behind what we call affected dentin or carious dentin in order to prevent a pulp exposure. If you look at the 10, 15, 20-year longitudinal studies that look at teeth with a direct or an indirect pulp cap and how many of them ended up needing endo, what you would see is that an indirect pulp cap is absolutely the appropriate thing to do, the more conservative thing to do, and the thing that gives the pulp of the tooth the highest likelihood that it'll have survived and the person will not have had a root canal way out into their future. So I love doing indirect pulp caps and avoiding direct pulp caps if I can absolutely do it. So let's continue our discussion about pulp capping and turn our attention to the different kinds of materials that we use when we do a pulp cap. So really there are two groups of materials that we kind of consider the gold standard. One is glass ionomer and the other is calcium hydroxide. They work phenomenally well. They help from a bacteria perspective, they seal the dental tubules, they allow the tooth to heal itself. When you're thinking about a glass ionomer liner for this purpose, you really want to minimize the amount of resin and you want a really low viscosity glass ionomer that's designed to create a very, very thin layer and act as a cavity liner or pulp capping material. So today we get calcium hydroxide in materials that contain what we call MTA, mineral trioxide aggregate. And then they leach calcium hydroxide when they're exposed to water. So lots of ways to get those today, lots of materials today that say they are bioactive is the terminology that normally means they have MTA in them because calcium hydroxide is the only bioactive dental material. It actually causes the tooth to lay down sclerotic dentin. It actually breaks down the collagen structure of the dentin, creates a biologic process that motivates the tooth to create sclerotic dentin. So all sorts of choices. What do I use today? I use a material called Theracal from Visco. It comes in a syringe that looks like flowable with a tip. Truthfully, clever thought for a delivery system. I don't use it. We actually inject it out onto a mixing pad. I pick it up on the end of a perio probe. You could use an endodontic explorer, a good old-fashioned die-cal instrument if you still have one, because you want to put it down in a very, very thin layer. It is a mix of MTA and resin, super thin layer, cover everywhere that you're doing your direct or indirect pulp cap, light cure it, and now you don't have to wait for it to set and you can go.